Hi, Dr. Gelato. This is Christina. I'm a pharmacist and that has been consulted on patient BT. She is a 30-year-old female from Swaziland, Africa. She has presented to the ER with complaints of night sweats, weight loss, fatigue, nausea, vomiting, abdominal pain, and white spots in her mouth. She's been diagnosed with HIV upon admission. She has presence of lymphopenia and a protein gap, and this has prompted HIV testing for this patient. BT's biggest concern is the presence of her white spots in her mouth. Treatment of HIV and subsequent infections are the main concern that we have right now. Her past medical history is not contributory for present symptoms. Her symptoms started a few days ago, and she denies any underlying conditions that could be causing her symptoms. In addition to her current symptoms, she denies rhinorrhea, cough, diarrhea, urinary symptoms. She has no known allergies, and her current vitals are blood pressure 103/62, heart rate of 97, respiratory rate 16, temperature of 102.1. She is 5'8". She has weight of 120 pounds, and her creatinine clearance of 119 mLs per minute has been a trend over the past 3 days, and this is normal. BT denies being on any at-home medications, OTCs, and her inpatient medications include normal saline, IV 150 ml per hour, continuous for fluid replacement, dextrose 50%, IV syringe, PRN low blood sugar per protocol, acetaminophen 650 mg PO Q6 PRN pain, Docusate 100 mg PO BID for bowel motility, famotidine 20 mg IV daily for GI prophylaxis, ondansetron 4 mg IV Q6H PRN nausea and vomiting, enoxaparin 40 mg sub-Q daily for antithrombolytic prophylaxis, potassium chloride 40 MEQ PO PRN hypokalemia, and Boost Plus PO BID for nutrition. BT denies BT drinks 1 to 2 beers a month. She denies any illicit drug use. She is single and has a history of 8 male sexual partners since the age of 17. Her oral mucosa is positive for cream-colored plaques. She has enlarged lymph node detected on the left neck region, but she is alert, oriented to person, place, and time, and BT is negative for cardiac abnormalities and edema. All other findings were normal. CT with contrast of abdominal region noted borderline splenomegaly. Her last CD4 count of 7 cells per millimeters cube and a CD4% of 1. Her lab results show that she is HIV positive she has HIV positive antibodies. We are waiting to hear back results for her HIV viral load and genotyping testing as well. Right now, her hemoglobin and hematocrit levels have been dropping over the past 3 days, and this is trending towards anemia. She has been diagnosed with AIDS based on her CD4 count, which is less than 200. The pharmacy team recommends initiation of combination of Truvada 1-PO-QD and Prescovix 1-PO-QD with food for a lifelong duration of treatment. Her symptoms are also consistent with findings for infection with MAC. We recommend initiation of combination antibiotic therapy of clarithromycin 500 mg PO BID, ethambutol 800 mg PO QD, and rifabutin 300 mg PO QD with a duration of treatment of 12 months. BT's white plaques in her mouth are consistent with findings for infection with oral thrush. We recommend initiation of fluconazole tablets, 100 mg PO/QD for 14 days. Due to her low CD4 count of 7, we recommend chemoprophylaxis of Bactrim DS PO/QD to prevent PCP and toxoplasmosis encephalitis until her CD4 count is over 200 cells per millimeters cube, which can be reassessed at follow-up. After treatment is complete for MAC and oral thrush, chemoprophylaxis can be considered as well to prevent recurrence of other infections. Prior to her discharge, additional counseling should be done to educate BT on the importance of adherence to her medications, as well as any side effects that can occur. Emtricitabine can cause reversible palmar-plantar hyperpigmentation. We also need to reiterate safe sex practices, avoiding risky behaviors, and notification of all of her past and future sexual partners. We recommend a consult with social work to get community resources for her as well. Follow-up with patient should be in 2 weeks to test for viral load and thrush resolution, as well as MAC. Her goal viral load is less than 48 copies per ml to achieve undetectable levels. After her first follow-up, the viral load should be checked every 2 weeks thereafter for the first 6 months, then every 6 to 12 months once her viral load is undetectable. Her CD4 count should be assessed every 3 months until it reaches over 200, at which point prophylaxis for PCP and toxoplasmosis can be discontinued. Her CD4 count should be reassessed every 6 to 12 months thereafter. At each follow-up, we check her renal function due to tenofovir, which can cause Fanconi syndrome, as well as we need to assess her medication adherence. If you have any other questions, please page the pharmacy team, and we'll be happy to help. Thank you.